Hello, Roger. It's a pleasure to be with you. Thank you so much for taking time for this conversation.
It's fantastic to be on Zoom with you. It seems a very long time since we were both in Buenos Aires together.
Yeah.
But great to chat and talk.
Yeah, and unfortunately, not many things have happened related to shoulder surgery since we met the last time.
Absolutely. My diary has been completely emptied.
Yeah. Roger, we met for the first time in San Antonio, Texas in 1993. We are getting old. So you were already not only interested on shoulder surgery, I think you have already published some of your papers. I remember the one about shoulder, not multidirectional instability, the one about laxity, shoulder laxity in teenagers that you published. That was around that time or a little before.
It was even earlier than that. It was in the 80s, the late 80s when I was.
The late 80s. Yes, it was already published.
Yeah.
Good.
No, on the trip to San Antonio, you're absolutely right. That is where we first met. And I was traveling with Pascal Boileau for 6 weeks around the US. And I was the first, or both of us together, we were the first European-American traveling fellows. And literally, we started on the eastern seaboard, but up in the north in Boston, and worked our way down. So by the time we got to San Antonio and Dr. Rockwood's unit, we'd been traveling for weeks and weeks and weeks. But it was the most fantastic experience.
I can imagine.
Great hospitality and obviously a great learning experience. And also a catalyst for forging links with colleagues across the world in all corners, really. A very interesting time. I learned a lot there.
Yes, well, you know that I stayed with Dr. Rockwood for 6 months, and being there was like every day was a surprise. People, not only doctors and patients coming from all over the world, from Australia. I remember a doctor coming from Australia just to get Dr. Rockwood's advice, and also colleagues from all over the world. It was very interesting. Yeah. So you are involved in shoulder surgery for many years. And what led you to choose this way?
Well, I'm of the generation where we were trained as general surgeons. And it's extraordinary now that my only qualification, the FRCS, is actually in general surgery. It included some orthopedics, but it is primarily a general surgical exam. So there was no possibility when I was a junior trainee of subspecialization. That was something that was almost unheard of. And the interest developed really as I was a chief resident. It was a neglected topic. Yeah. The protagonists of English orthopedic surgery were quite bewitching. They were very distinguished people, slightly unusual people, Lippmann Kessel, people like that, and Steve Copeland, of course. Yeah. So it was just beginning to get traction, and then I'd done pediatric surgery, and indeed my fellowship training was spine and pediatrics in Hong Kong, not shoulders. I'd done quite a lot of knee surgery as well, so it came quite late. And the exploration through a traveling fellowship in Europe was a catalyst. And undoubtedly, the opportunity to meet Christian Gerber when I was very, very young on an AO fellowship was terribly important. And I subsequently went back to see him afterwards. But no, that's how it started.
Good. And which people would you choose as your mentors on shoulder surgery?
That's an interesting question. Unlike modern day training, it was very much a program of education that I constructed myself. So Chris Constant was one of my bosses in the very early days, but I didn't come from a training program with a distinguished shoulder unit.
Mm-hmm.
So I suppose the person I would often and I'm sure you find exactly the same, often the people you remember most fondly and with most gratitude are the lesser known people. But Norbert Geschwend was a giant. I mean, he was absolutely fantastic. He was hospitable, he was a gentleman, he was a polymath, and he was extremely sensible. And even beyond that first educational visit, he was someone I could go back to and ask for advice on specific problems. And I remember one particular one on elbow replacement, which he was very helpful for. And I think similarly, I mean, obviously on that travelling fellowship, we met Dr. Rockwood, we met Charles Nears, Carter Rowe.
Yes.
But some of the people who taught me things that I used throughout my practice were people like John Fenlin, who really wasn't known that widely in Europe, certainly. And Dr. Leffert, Bob Leffert. I mean, the two operations that I learned for him were the treatment for winging scapula, which Eden Langer, and then also Marmer and Burstall's procedures. But in terms of helping patients as a direct consequence of meeting an individual, they're two people I would certainly state.
Good. And I know that there is another doctor that has influenced your life, that is Dr. Cronin, Archibald Cronin.
Oh, yeah. I know what you're referring to.
Yeah.
In this long lockdown period, I rather delayed it. I was invited to actually consider what I'd actually learned in my practice, because I've retired from clinical practice. And it's a very interesting question, because learning and acquisition of knowledge is one thing, but to actually leave something that you feel is important. This article focused the mind. And for me, there's no doubt about it, the passage of my career through specific regional areas around London, and the patients that were treated in those hospitals definitely colour the way I think. And when I say colour the way I think, I mean, decision-making, discussion of risk-benefit ratios, which I think is absolutely paramount important. And most important, I really stress this, is informed consent. And this journey took me from a wonderful opportunities of training in London, in Cambridge, in Hong Kong, Kennedy Institute, all sorts of places. But it took me to 3 hospitals, which are relatively close together in the northwest sector of London, namely Central Middlesex Hospital, St. Charles, and then St. Mary's, which is one of the big teaching hospitals. But they were all characterized by serving a population of great diversity and a degree of poverty. It's awful to admit that in a big city like London, there is still quite a lot of poverty. And those patients cannot be treated by what we learn at conferences, simple results. There isn't. Again, this was part of the message that when I started, there really wasn't much data. There were case reports, there were small series, usually retrospective. But now we have got pooled data, we have registries. The pooled data is important. It's often acquired by excellent centres, by great enthusiasts and skilled surgeons. So one cannot assume that your practice can be parallel to that. But you cannot treat patients who struggle with many aspects of life in the same way as you do with someone who is a professional ex-sportsman in a wealthy area somewhere else in Europe or in the United States. So going back to A.J. Cronin, and that's what you're referring to, he was a general practitioner. He was Scottish originally, and he came and worked in my area. And indeed, his practice served as my general practitioner. But he wrote a book called The Citadel.
Yes.
And it's a moral tale of a man who comes to the great city, to London, to the private practice hub of our country. And he comes from the Welsh valleys.
Yes. And
it basically charts what happens to him. And it made a fantastic film, a very successful film with Harrison in it and all sorts of people, which actually was nominated for Oscars, Best Film, Best Actor, and a very important book. And I think the only other thing I would say is that it's provided a very good gift, because when people leave their training programs, they go off into independent practice, and it's quite good for them to actually read this book. And some of my trainees have got that, and some of my other trainees have had Codman's book, according to their need.
Okay, that's interesting. Yeah, I read The Citadel when I was, I think, 12.
Very good.
I was 12 years old, more or less, and the impact that made to me, it was very important. Years later, I watched the movie, but it was really very interesting how this young doctor needs to deal with a very complicated context, no? And it makes sense with what I read in a paper written by you about how, and you are talking about this now, how the place where you practice influence on you, on us as doctors. And it's very interesting because in some way, what you are saying in your paper is the same thing that this guy in the Citadel is telling, that how his life and his practice is influenced by the context where he's working. So it's interesting, very interesting. I think it should be kind of part of our education as doctors to read those books. Not many people know about the Citadel, for instance, no?
No, I think that's right. I was surprised to hear that you'd read it. The other book that I used to encourage my trainees to read was Axel Munter's book of the story of San Michele. This is predominantly a book that he wrote when he was in Naples. A lot of it's about building this wonderful house that's in Capri. But in addition, he talks about the cholera epidemic in Naples. And also, which is much more relevant to the shoulder, his time in Paris, where he was a student of the great Dr. Péan. Oh. And you may recall that he said some fairly awful things, which I certainly couldn't repeat on this interview.
I didn't know that.
No, and this was someone who we revere as one of the pioneers of our subject. Undoubtedly, the first metallic shoulder replacement was inserted by him in 1893.
Yes. So, I know that.
But as a doctor and as a human being, he may not be someone we should be admiring so much. But that's a good book to read.
So it's better to speak about his prosthesis, not about him.
About him.
Yeah. About him. And speaking about prosthesis, which was your favorite procedure in shoulder surgery?
I think it probably was arthroplasty. The gains of arthroplasty during the period of evolution of my career, they emulated what our colleagues in the hip and knee were achieving, undoubtedly. We were seeing patients really get pretty much normal function. And that is something that was hugely important, whether it be an osteoarthritis, post-traumatic arthritis, or indeed a subject I was particularly interested in inflammatory arthritis, rheumatoid. So I think arthroplasty was important. Obviously, we've seen recent changes in what we believe is the right type of arthroplasty. Sometimes I find these quite difficult to consider. But no, that's, obviously the three pillars of rotator cuff instability and arthroplasty, but arthroplasty is important.
Yeah.
And again, if one thinks back to the contribution that Dr. Neer made and Dr. Rockwood, seeing those patients achieving upper limb function was very formative for me.
Yes, yes, of course. And there is a aspect of your life that I think it's very important to talk about. That is your relation with art.
Yes, this has been slightly overhyped, I think. Pascal Boileau was president of CESEC, and as a good friend, based on our traveling fellowship, he asked me if I would give a lecture. And I think the subject he wanted to talk about was partial thickness tears of the rotator cuff. And at that time, and actually, to be honest, not much has changed, but I knew virtually nothing about this condition. Well, certainly I didn't know how to treat them. And I remember saying to him, Pascal, that's very kind and very greatly honoured to be asked to do it. But I'd rather speak about art on the shoulder than partial thickness tears. And in his typical style, he said, Roger, that's it. That's what you're talking about. And my belief at the time was, well, I could probably do it early one morning in a sort of minor room. But I ended up doing it as part of the opening ceremony. And again, that was a fascinating, like everything, whenever you prepare a lecture, you learn. So what did I learn from that? I've always been interested in the arts and collect a bit, but I learned about forms, how the shoulder works in space. I actually had to learn a little bit about ballet in order to understand the shoulder and art. I had to go off to tutorials with famous ballet teachers and even go to ballet, not me, but go to watch ballet classes to learn about épaulement and Cicchetti's method and things. So no, it was I'm sure that's what you're referring to. But no, that was fun.
Let me ask you, which is your favorite painter? Is there someone that you could choose?
I mean, obviously, you're expecting me to talk about some great Renaissance master who depicted surgical...
Not necessary.
No, I think I'm definitely a 20th century man, and I'm a great admirer of Paul Klee. I think titles are as fantastic as his pictures.
Good.
And I had a very good friendship with the man called Carl Gerassi, who was a great organic chemist and the inventor of the contraceptive pill. And he exclusively collected Paul Klee. And we used to have long conversations about him. So I suppose that's an answer.
Well, good response. And let's move back to shoulder. How do you see shoulder in Europe? Shoulder activity, which are the plans for the future?
Yes, I mean, I've been, ever since the traveling fellowship, really, I've been totally committed to the European Society. Admittedly, also the British Society, but they offer very, very different things. So the European Society is a wonderful organization. It delivers benefits to our membership. It has great congresses. And we've been very lucky. Over the last 20 years, Europe has actually played a major part in the development of shoulder surgery. But I suppose that the thing that has been fascinating is how the borders of Europe have changed. And it started, I think, really in Budapest under Herbert Resch, who quite rightly said that the center of Europe is somewhere close to Vienna, that we should export what we've learned and what we can help with to countries that were previously part of the Eastern Bloc. And I remember a group of us met and we were allocated countries, and I got Hungary and had a fantastic time of repeated visits to not just Budapest but other cities in Hungary. learnt about their culture, their food, and made good friendships. And that has been, I think, the first steps towards what is happening next year. It is next year now, because it was going to be this year. Yes. And that is the Poznan conference. And Shemo Lubatovsky he's a fantastic organizer. It will be fantastic. And I use this as an advert as much as anything else. If you can, do attend. But he will be reaching out to areas that have traditionally not been represented very well. So Ukraine, Belarus, Russia itself, Baltic states, as well as the traditional groups. And it's a great venue. It's affordable. You can get in your car and drive across Central Europe, and you can get there. So I'm very excited about that. And I would like to think that was one of my ambitions as president and going up the presidential line. So that's good. And I think, and again, on the other side of Europe, and I mustn't make this political, but inevitably the changes within one's own country will affect the way we integrate with Europe. I know everyone says we're great Europeans still, but I do see changes. And I see the situation where we're all essentially employed by one employer, the National Health Service, tends to make us slightly isolated, but also means that the surgeons share a common professional career, really, and problems as much as anything else. So it's fascinating to see, and I know we've talked about this before, how Ireland have suddenly emerged as a country that is integrated into Europe, which is not necessarily the case for the UK. And as a consequence, another aspect that gives me great pleasure is that we're going to Dublin, which is a wonderful, wonderful city.
Yeah. So. We organized a month ago, more or less, a webinar with the Irish Shoulder and Elbow Society and the Argentinian Shoulder and Elbow Society, because in fact there are many things in common, like rugby players, and it was very interesting. And we are having nice plans with the Irish Society, and I see that they are moving on and have a lot of projects with a lot of energy. I'm very happy about that.
Yeah, and also hopefully will be a catalyst for strengthening the links with North America as well. The strong links with Ireland, but no, that's so. I think Europe is doing well, and then of course the other. Sorry, I'm advertising now on behalf of my society, but yes. Rome will be a wonderful place to follow Argentina.
Yes. I hope that for that time things are going to be easier to travel around the world, because it's a great destination, and I'm sure that Alex Castagna will organize a super meeting. Yeah.
Absolutely.
Yeah.
Absolutely.
And speaking about the future, what about your personal future? What are the projects you are involved now? I will not expect you to be quiet.
Well, I'm being forced to be very quiet because I can't go anywhere at the moment. So I'm locked down.
Yeah.
No, I think, obviously, again, this has re-examined. I'd made a decision to stop clinical practice. That decision was largely to pursue areas of research. And I think I have no regrets on that. I got to the stage where I'd achieved as much as I probably could for my patients. And the questions that needed to be answered were really in the lab and from big data sets. Sorry, I'm going to cough. We were very lucky. It's sort of a bit of a gentleman scientist, really. We've got different areas of activity, and that's a bit of a luxury. But the sort of major things that we've been involved in, we had a very large Wellcome Trust grant to look at conventional shoulder replacement. I've probably been quite slow to adopt reverse. It's never, I came from reverse in the beginning, and from the Kessel prosthesis.
Yes.
I saw it disappear, and it's quite hard for me to see it return, and to see it return in a better light. I know I'm wrong on that. I have no doubt about it. But I do worry about a prosthesis which, even in the best hands, most experienced hands, has a complication rate of 10%.
Yeah.
And again, as I was saying much earlier, we know what we can achieve with prostheses. What we don't know is the disability level and the consequences of complications. And that's important. The other thing is, which I've written about previously, is about informed consent. Can we really turn around to a patient and say our complication rate in the very best centres is 10%? I mean, there are no general surgical colleagues who are doing that. So that's an issue. So I was still interested in conventional unconstrained arthroplasty. And all the questions have remained the same for the last 20 years. And our research activity answered a few, and it raised many more questions. I suppose, in simple terms, my message would be that ceramic prostheses potentially offer advantages. They may offer advantages, particularly if you use them as a hemiarthroplasty, which is a very UK tradition, Steve Copeland, etc. And I've as yet, and this goes against my own belief, I've really as yet failed to show that total shoulder replacement is any better than the ceramic hemi, which is interesting. I suppose I have misgivings about putting in a shoulder replacement where you have to detach half the rotator cuff envelope, the subscapularis. Mm-hmm. That may seem totally acceptable for a reverse, but is it the right way forward? And again, on one's travels, I've seen and often used the posterior approach to access the shoulder joint. So the idea that you could put in a prosthesis through an interval incision or a non-muscle tendon dividing incision has an appeal. I think the other thing that I worry about is that we've sort of slightly lost the ambition that we had on the glenoid side. If you think back to Dr. Rockwood,
yes,
hemiarthroplasty was something he did. Dr. Matson effectively does a ream and run.
Yes.
These people with their experience should be teaching us a lot that the glenoid component may not be necessary. The other thing, if I think back, is that when a glenoid was required, it was fashioned in a very skilled, sculpted way. We've gone down the route of other arthroplasties where everything is done by a guide wire. And to be absolutely honest, our knowledge of glenoid anatomy is such that we don't really know what is the optimal position of a guide wire. And the consequences of being constrained by a guide wire is that you break the subchondral plate. And as I know from being in the laboratory, to get a cemented or an uncemented glenoid to actually become stable in that sort of environment is very difficult. And we don't see those problems by cohort studies. We don't rarely see them even with registries. But if we use sophisticated imaging, and I suppose this is an area that I will continue with, I work with a Swedish company on this, I think we can actually look at the behavior of our components the amount of fixation, the amount of bone damage that occurs, using techniques that are readily available and just require technology and algorithms.
Yeah, well, it's very interesting, your position, because being in this business for 30 years, I'm sure that you and me have seen many different waves of new fashions coming and going, and people who are saying one thing today, tomorrow they say just the opposite. And it's good to see things from out of all these kind of, I don't know, craziness or whatever, but it's like there is a direction, and all the people's going on that direction. And I think it's good to see things from another point of view. It's very interesting because we have seen many patients with hemiarthroplasties by Roger. He did not use any kind of guides. Of course, he was a very skilled surgeon with a lot of experience, and he had good points about hemiarthroplasties and some points of view that in some of their papers, his papers, he speaks about concentricity, just that the point. I remember one of his last papers that when he got concentricity, he had with hemis the same results that are reported for total or anatomic arthroplasties. So there are topics that there are a lot to learn. It's not everything, known.
And also, the shoulder, I'm not sure if this is an attractive feature, but the spectrum of the conditions we treat is far higher than others. I mean, essentially, the hip and knee, it's about arthritis. I mean, we have a whole variety of patterns of arthritis, but beyond that, causes for post-traumatic arthritis as well. So I think we have to remain open to different things. And of course, our age group is different, and the requirement for longevity of the prosthesis is different.
Roger, I see that you have a lot to produce, to give to our shoulder community. So for sure, we will meet in Italy.
Definitely, I will be in Rome.
Yes. I really appreciate very much the possibility to talk to you and learn from you. And I hope we will keep in touch.
Thank you very much for the opportunity to talk to you, Daniel.
Thank you very much.